Every once in a while, you run into somebody and you realize, holy cow, this guy knows a lot, and I need to just pick his brain. Thomas Asfeldt is a guy that is not just a doctor. I shouldn't say just. He is a guy who's an expert in all facets of medicine in this country. He's the guy where if a healthcare system is looking for a temporary leader, they'll hire him to come in for a few months to a year to figure it out. So he has seen all kinds of healthcare systems in this country. And generally speaking, he says it's not looking very good and it's really expensive. And does he have some money saving ideas that are going to save you hundreds, I'll say even thousands of dollars? You're going to love this interview. We'll have him back. Like, share, subscribe, get your comments in. Your questions that you'll send to me, I'll have him come back and answer. In the meantime, I'm really excited for you to hear and see this session of I Like That Story. Hi, I'm Jeff Gould, America's Storyteller. I do this program, and you don't know this, I do it just strictly for me when I reach people that have interesting things to say. And you want to just quiz them, but they're looking at their watch going, buddy, I gotta get out of here. So I was able to hook Thomas Asfeldt up because he knows a lot about what's very important to you and I, your healthcare coverage. So I wore him out at some place for like 10 minutes at a coffee shop and realized that what I really needed to do was pick his brain for about an hour. But since he wouldn't be willing to do that, I'm sure, I thought I'd invite him to the show and then he would feel like it's for everybody, which it is. But primarily, it's for me.
Perfect.
Thomas, how you doing?
I'm doing great. Good to be here.
You've always gone by Thomas, never Tom
Always.
or Tommy. You've
Absolutely never Tommy.
Never Tommy. Never
No.
Tommy.
No.
I was thinking maybe in college, no, never Tommy.
Always Thomas.
Okay.
So I never even had a nickname.
No kidding.
Never had a nickname. No, although my kids now call me Tom Jones once in a while, which kind of works sometimes because my last name is not the easiest to spell. So if I'm in the old days ordering a cab or now making a restaurant reservation, I just say Tom Jones and they say, really? And I say, oh yeah, I get that all the time. Tom Jones.
It's not unusual, right?
Right, exactly.
Well, just so you know, I emailed you and AI is so helpful. It continually tries to call you asphalt. So just so you know, they're trying to create you into a road surface. That's not really fair, but there we go.
That's okay. I've been slapped down once in a while in my life, so it works.
So whenever we do this program, we always send out interview questions in advance so you have some time to prepare. Some of it's just fun stuff. Some of it, I'm going to pick your brain about our industry. Now, you'll have a chance to ask one question of me and only one question. You can't just one question.
All right.
And we're going to save that to the very end.
Okay.
But for right now, just to start, let's see our Jeopardy question of the day. What Jeopardy question would you like to ask, Thomas?
Well, Jeff, I think I'll take quite the character for 800, please.
Quite the character for 800. Okay, here do we have. Good. If you could have lunch with any fictional character, who would it be?
Yoda.
Oh, Yoda.
Yes, Yoda. So Yoda, he is quite the fictional character, as you know. But I like Yoda. I'm a Star Wars fan. I remember going to one of my first movies, going to the first Star Wars, A New Hope in 1977. But Yoda, he is wise. He's humble. He's trustworthy. He does everything to help others. He always does what is right. He has a sense of humor. One of his quotes that I actually use in my work, and actually you'll find it on my LinkedIn profile, is do or do not. There is no try. And I really like that one because when oftentimes you ask someone to work on something or do something, or even myself, well, I'll try that. And really when you say that is you're giving yourself an excuse to fail. And so I love that quote from Yoda, do or do not, there is no try. But I love Yoda. He's great. You know, this little
Do you ever say that to somebody?
Absolutely.
You say did you say it with the Yoda? Can you do Yoda? Can you do the Yoda voice?
My wife's really good at Yoda, but I'll give it a shot. Do or do not. There is no try. Yeah, I'm terrible. My wife's really good at Yoda. I'm terrible at it. But
so when you go to lunch,
Yoda. He's a great character.
I'm asking you. So I would say, where would you take him to lunch? But what I should say, what lunch would you take, or whatever, however we give him.
Yeah, that's right.
What lunch will have you now?
What lunch take me to? Would you?
Exactly.
Yeah.
Well, of course you know. Where are you going to go?
Where we're going to go? Probably Tatooine.
Tatooine. Oh,
that's
yes.
Right.
Isn't that a planet somewhere that they eat? Is that right?
Yeah. It's a planet with a whole bunch of lively characters.
Okay.
I think, Jeff, you need to watch a little more Star Wars.
Correct. I went along to the first one. It was fantastic. I went along to the second one, loved it. Saw the third one, loved it. And they said, well, actually, that's the middle of 9. And I said, okay, I'm done.
Yeah, there you go.
All right. I'm a little bit. In fact, I'm going to ask you as a related question.
Yeah.
If I could give you a functional lightsaber, would you take it? And how much are you willing to pay for it?
A functional lightsaber, would I take it? And how much would I pay for it?
Yeah. Okay.
Well, would I take it? Yeah, for sure. Would I pay for it?
How
no,
much? Which you and I are in a bidding war. Silent
Wait, is
bid.
this the only one on the face of the earth?
I think so. Yeah. So it's and I think if I understand how my lightsabers work, only you can use it. So it's not like, I'm going to give you the ability to use a lightsaber, and we're silent bid. So it's at the silent auction. So I'm writing on a piece of paper, you're up against the, everybody.
I don't have enough money. The only functional lightsaber on the face of the earth, I couldn't afford it. But I'd pay you $20,000 for it.
Okay. $20,000 on the lightsaber.
There you go. But
so here's what I'm going to ask
I'd
you
have to sell my car.
Here's what I'm going to ask you to do. Send me $20,000 on deposit, and I'll start looking. Okay?
All right.
And I'll let you know when I find it. Actually, the reason I bring it up is that and this is perfect. This is a perfect roll into what you do. How many minutes would you own a lightsaber before you would damage your house or yourself or somebody you care about? Right? I mean, you're going to slice through that wall behind you. You're going to turn it on and accidentally clip off your left forearm. I mean, those things are serious.
They're fantastic.
Nobody shows the learning curve and how many Jedi Knights were accidentally sliced in half in the training process.
Well, I'd go back to your question 1, and first I'd go have lunch with Yoda and have him teach me how to use it.
This is Yoda having lunch with you. I think he's already chewing. There's no food going into his mouth. He's not. I don't think he even needs to lift. Maybe the utensil hovers up and he does this.
Correct.
But I think he just kind of mind absorbs it and just goes, interesting.
Yeah, exactly.
Good lunch for you to have.
So you want to be a Jedi Knight, Thomas?
First, you must know healthcare inside out. Okay, so and that is your ballywick. Oh, I did this again.
Yeah.
I tell you what, Booker gets so angry with me. I'm supposed to introduce our guests and read their
and you
bio.
Forgot. That's okay. That's the great thing about editing. You can clip it back first and pretend you did it the right order.
That's not going to happen. He's just going to chop it in and then point. In the comments, you can complain about my interviewing skills. Thomas Asfeldt is a healthcare leader, interim executive, and mentor with decades of experience across nursing, oncology, life sciences. From the ICU to national cancer initiatives and federal research projects, his career has been defined by one core mission: improving lives. And I'll get to the rest of it as we continue in our interview. But what made you decide to? I mean, everybody likes. I shouldn't say. A lot of people want to help people.
Yeah.
Why did you choose healthcare as the avenue to do that?
Yeah, I'll go back probably quite a ways. I grew up in a healthcare family. My father was a physician and my mom was a nurse. They're both since deceased many years ago. And so I grew up in surrounded by the health professions. So obviously I was influenced by that and I saw it all the time. So I think, we choose things that we're influenced by in our life. And so that was clearly evidence that serving others was really, really important. So I think that was probably the most influential. The other part of it is, I think part of my nature and being a Christian is service to others. And so I think those things together, as well as I just love the sciences. I think you put all those things together, and that's how I chose this profession and serving others. And as life went by, I realized I have a very analytical mind, a strategy oriented mind, that I can consume a lot of different information and figure out how to best use that to maximize my efforts to serve others and tackle problems and those sorts of things. So that's my 30-second summary.
So I have a number of friends and relatives in healthcare, and they will talk about, how will I say this? They'll talk about the system, and
Hmm.
you have to follow the rules of the system. And the rules of the system don't necessarily, strangely, put the health of the person primarily at the top.
Yeah.
And it's just interesting how maybe they did it on purpose, maybe not, but it just seems to be, as my brother will tell me occasionally, yeah, it's just, you just kind of give up and do what the system tells you. And I thought, I don't even know what he meant by that,
Yeah.
but maybe you know what he meant by that.
Yeah. I think, you know what a normal distribution looks like, right?
Yeah, I mean,
20,
you're
10,
talking like a
10,
bell
80, 10,
curve,
right? Yeah. A
the,
bell
the,
curve.
the bell curve. All right, yeah,
Yeah. So I think, sorry, you said that was your brother in law?
yeah, brother, yeah.
Brother, everything follows a normal distribution.
See
Yeah,
that?
I
I
can't
mean,
see that's a white piece of paper.
I know,
Yeah,
right?
I know what a normal distribution follows like. So, your brother's probably stuck in the middle. He's just stuck in the 80% now of fighting the system that's not necessarily designed for the best outcomes, for the highest quality, for the lowest cost. And that happens to everybody after a while when they get so frustrated that they just feel like they can't make any difference. And that just doesn't happen to me for whatever reason. I don't know if it's if you say it's innate or I just haven't given in. Um, but I always want to stay at the top 10%. We're constantly trying to improve the system for the benefit of the patient because that's why the system is there to improve what's there for the patient. And I'm gonna tell you, you like stories, so I'm gonna tell you a story.
Yeah, yeah.
And I gave you several stories. I told you this one of the stories I wrote to you about briefly in just a brief paragraph was my best friend Michael. And I might cry a little bit because I love Michael.
Hmm.
He's passed away several years ago from lung cancer. He was diagnosed at 44 with lung cancer, way, 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 way too young. And it was self inflicted. He smoked for a long time, and he was good at quitting. He did it many times. Yeah, that's the story about the terrible nicotine addiction. So when he was diagnosed very late stage lung cancer. His likelihood of surviving 1 year was 50-50. Fortunately for him, he survived 13 years after his lung cancer diagnosis.
Oh my.
He was very, very fortunate. Um, why did he get to survive 13 years? God intervention. He was one of the fortunate ones that responded very well to his treatment. One of the downsides of surviving 13 years after your cancer diagnosis that he had is that he developed secondary cancers as a result of the treatment.
Because the
He
treatments are by their nature carcinogenic. They cause cancer.
Correct.
Okay. All right.
Yeah. You survive long enough, you're going to get cancer from the treatment that we give you. Not everyone, but people do.
Mm.
It's a known side effect. So he died as a result of a secondary cancer that he got from his cancer treatment. But he lived 13 years, many, many, many years longer than he quote unquote should have lived. And that was great. He got to see his kids go to college, or sorry, got to see his kids graduate from high school. His kids were 5, 6 years old when he got first diagnosed. So he got to
Mm.
do a lot and see a lot of things. But those 13 years were not without trouble and struggle and strife, because the system's not inherently designed just for his best outcome, both from a financial perspective, both from a simplicity of getting through the system perspective, both from a coordination among physicians, groups, people, use your adjective perspective. And so and this was early when I got started in working in oncology, not very many years after I got started working in oncology. And I started to realize that the system is, even though I'd been working in healthcare for probably 15 or 18 years at that point, that if we continue down this path, um, we are all going to have significant difficulties in our healthcare system, more than we already have. And I became very passionate about advocating for healthcare issues, both on the state and national level. I went to Washington, D.C. every year, a couple times a year, went to Peer once a year to talk about healthcare issues and things that we could do differently. And my work within the healthcare system always focus on quality of care. What we're doing is the best? Can we do it better? How you're never satisfied? How can we always do this better? 1% better is 1% improvement on someone's life outcome. How can we do it better? But it's always focused on the patient. So I spent a lot of time learning what other people are doing, and now as an interim executive, I get to go a bunch of places around the country and see things differently.
That means you just
And
are filling in for a period of time as
yeah,
an executive. Is that right?
yeah.
So
So I'll go
you're
one place for 3 months, one place for 9 months, one place for 15 months, and you see a lot of
do you wear a
different
cowboy
things.
hat? I feel like you
Yeah,
wear a cowboy
yeah,
hat and walk in. Who's a
yeah.
stranger? Yeah.
Yeah, well, it kind of is that. Yeah, the kind of is that way, right? And you have to add value to the organization the first day you walk in the door. That's what you're expected, and that's what you do as an interim healthcare executive.
So,
But
this
y'all,
is. I'm going to ask you to tell
yeah,
that story real
yeah,
quick about the
yeah.
people who thought you were spying on them because you kept
Oh yeah, that
clicking
was a
at
great
something.
story. Yeah, yeah. I was like, so I have insulin dependent diabetes, and I wear an insulin pump, and so I have it on my waist, and I every time I go somewhere new, I spend time talking with people, getting to know them. What do you do? Tell me about your job. What works well, what doesn't work well. What do we need to fix? Because it's always the front people on the front line who know what's happening, right?
Yes,
Know
yes,
what we
yes.
know what we need to do better. It's not the bosses that knows what's you might think what's best, need to change, but really the frontline people always know. They've always known
Yeah,
what
yeah,
need to improve.
yeah, yep.
So I always go out and talk to all the people. Sometimes I interview every single person in the organization. So I was doing that, out walking about, and some people didn't know what an insulin pump was. So one person had started this little conversation. Oh, he's recording all the conversations, recording all the conversations. Because I had my insulin pump, and every once in a while it bugs me, so I just adjust it, move it around on
Sure.
my hip.
This meant
And
you were
so,
turning the recording device
yeah,
on. So, what do you
so
really think about this place? Click.
yeah, click, click. So I heard this rumor. So, and then I heard who it was. So when I was meeting this person one-on-one, I said, I'll just say this person's name was Jeff because you're here. So I
Sure.
said, say Jeff, I heard this thing that you think I'm recording conversations. And Jeff got a little sheepish, and I said, have you ever seen an insulin pump? And I pulled it off my belt with my tube and connect to my body, and Jeff got rather embarrassed. And I said, so yeah, this is an insulin pump, gives me insulin all the time. And I said, so Jeff, you know what you need to do now? Jeff hung his head low and said, yeah, I need to go tell people what really was going on. I said, yeah, that'd be great if you could do that. That's taking ownership. So yeah, it was hilarious recording all the conversations.
Because everybody knows when you record, you do this with your collar. Everybody knows that's
Right.
where the
Yeah,
listening
exactly.
device is. Come
Yeah,
on
no,
now.
I usually just go like this. Start, record. Yeah.
So you walk into a lot. Okay, since you've been all of these places,
Yeah.
I get on a scale of 1 to 10. What is a grade healthcare in the United States of America?
Overall,
Yep.
You talking about A, B, C, D, E, F, G? Sorry, A, B, C,
One to
D, E,
10.
F.
1 to 10. A scale of 1 to 10 is like we're living forever. This is utopia. You know, one is you're on your own, and we're using whips to beat out depression with people in cells, right? Something from the Middle Ages, right?
Boy, no one's asked me that question, but if I'm honest, C minus or D. And here's why I'll tell you that.
Okay.
Um, we spend more on healthcare per capita than any country in the world by a mile. Okay. Life expectancy in the United States is less than it is in Cuba by about 4 years.
Hmm.
In Cuba, 81 versus 77. How's that
Well,
for?
have a nice day.
Oh,
That's good to
well,
know all this.
have a nice day.
Yeah.
So, we do, if you get really, really sick, come to America because we are really good if you're really, really sick and need tertiary care. But we spend almost nothing on primary care and prevention. In North and South Dakota, 2%, 2% of Medicare dollars are spent on primary care. 2%.
Tell the Louisiana story, because I thought that was fascinating.
Oh yeah, the Gulf Coast.
Yes.
Yeah, the Gulf Coast. So you get what you incentivize. You know, that's true for everything, right? You know, you want to sell this option on a car, you incentivize it, you get that, right? Doesn't matter what industry you're talking about. You
Hmm.
get what you
Hmm.
incentivize.
Right. Right.
That's very, very true in healthcare. And if you look at the history of healthcare, we've gotten where we are today because we've incentivized to get what we get. And we've incentivized high cost, high value procedures. So we've incentivized that. We pay more for it. And the more you do, the more you get paid. So that's a part of why we have the system that we have. And that's
So
not,
so I'm just gonna
yeah,
maybe paraphrase that to say,
yeah,
so let's say that I'm, the Acme Hospital,
yeah,
and it's this guy has, I'll say high blood pressure, and you can take
yeah,
this pill, which I sell for $10, or we can do this procedure, this operation, which costs, $150,000.
yeah,
How does the hospital make the most amount of money? That's the incentivized you talked about.
correct. Yeah,
And, I'm not going to pick on hospitals. I think that's true with everything, everybody,
yeah,
everywhere.
yeah,
What am I going to sell? Well, what am I going to make the most on? What am I going to do for a living? What pays the most? What task? I mean, when we attach dollars to it, it can't be surprising that we're trying to sell the thing that makes me personally the most amount of money.
right.
Okay.
And when 19% of your GDP is healthcare dollars, that's
Yes.
where we are today, right? And so, and it's not, evil people. There's everyone, I shouldn't say everyone, almost everyone in healthcare, really good people, doctors, nurses, administrators, radiation, everybody, just, everyone, not evil people, just working in a system that's designed to be
You
the
would
way
you
it
would talk
is.
to them, and they would say, "This is why I got in the business, to help people just like you." All right.
Yeah, exactly.
Okay.
So the Gulf Coast is an example of you get what you incentivize. So the Gulf Coast, you think of Louisiana, Arkansas, Mississippi, lower socioeconomic states in our country than you think of the Northeast, right? High income states. So lower socioeconomic states have much higher incidence of Medicaid. So Medicaid are people who have, when they come to see you, their payer source is significantly less. So it might be uh, 30 or 20 cents compared to someone who's privately insured. So you and I don't know what your insurance status is, but I'll just assume you and I have private insurance, and we come in, and the payer, what the hospital or the doctor gets paid is pretty good. The payment's quite high. But if you're on Medicaid and you go to see a physician or a hospital, and what the institution gets paid is relatively low, might be 20 cents on the dollar or 25. No, I shouldn't say on the dollar. 20% compared to what some of the other payers are. I shouldn't say on the dollar. That's not right. It's compared to the other payer rate.
So I walk into the doctor and I
Yeah.
say, I've got an ache in my side. And he said, okay, we might want to do retests. Show me about your insurance. Well, I don't have any. Oh,
Yeah. That's
well,
yet another
yeah.
group.
Yeah,
Yeah.
but I
That's
mean,
another group.
maybe I have this, is it Medicare?
Medicaid. Medicaid.
That's the
Medicaid is
state
for
one.
the,
Yeah.
yeah, Medicare is, what you get when you turn 65.
Okay.
Yeah,
Medicaid.
federal.
I
Yeah.
have Medicaid. And he goes,
Medicaid is administered by every state, has a different Medicaid program.
so I go in
Yeah.
and I
So
look at, he looks at my state Medicaid and he looks at the chart and he says, okay, if I do this test on this guy, Medicaid is going to pay me $42.38. I make
yeah,
way more if he comes in with Blue Cross Blue Shield. Oh,
they're going to pay me $400.
yeah.
Yeah. So in the Gulf states, Ochsner Health is the primary health system down there. It's easy for them to recognize, what do we need to do to keep these people out of the hospital? Because if they're in the hospital, we can't afford these high cost procedures because they're all money losers. I don't want to make this sound like they're evil people because we only want them in there if they can make money. That's not the case. It's how do we keep people healthy and well so they don't come into the institution? And this population has a high incidence of high blood pressure, diabetes, and asthma. So what they've done intentionally is spend their efforts and focuses in the community, keeping people out of the hospital, helping them manage their diabetes at home, helping them manage their hypertension, helping them manage their asthma so they don't have exacerbation of asthma, so that they don't end up in the hospital with a high cost incidence of something that's completely or almost completely preventable. So
So let me,
yeah, go ahead.
so let's say that, and if you own a business wherever you are, and
Yep.
that you have some clients you're going to make profits on, and some people, well, you got to take them anyway, but I'm going to lose money on this. But if I get the right ratio of 60% people who have good insurance and it should all work out.
Yeah.
But if it ever tips over and goes the opposite, my whole system is going to go bankrupt. So I really can't afford to have all of these people come in super sick. The only way I can make this thing work is if I send Nurse Jenny and Nurse Jackie and Nurse Allen out into the community to door knock and talk to people and say, Thomas, what's with the high blood pressure medication? How come you're not? And is that what are the ones that people are chronically underdoing for themselves? Is it diabetes and health and heart medicine?
It's the things that and this is going to be one of your last questions. If I had my two or three things in healthcare, what would I do? I know we're getting there. So it's the things that we know, or if you're on Medicare, you have lots of social determinants of health, right? That it's very difficult to stay healthy. Are you taking your medications? Are you in a smoke-free environment, right? If you have asthma and you have a smoker in your house, we got to get the smoker to quit smoking, right? Or if you have diabetes, do you have access to the right foods to manage your diabetes? Are you testing your blood sugar? Do you have insulin available to you? If you have a low socioeconomic index and I don't have a refrigerator and I live in the South, how am I storing my insulin? Because if it's 105 degrees and my insulin gets fried every time because I don't have a refrigerator, that's a problem. So there's all these multi-factors of social determinants of health to help manage people, to manage their diseases, to keep them out of the hospital. Am I overweight and I can manage my weight? Now I'm no longer diabetic or my hypertension goes down. So help managing their disease process or their lifestyle process or their environment or the other social determinants of health to help manage their disease. All things that you and I should be doing. But if you're in a circumstance or situation where they're exacerbated, their diseases are also exacerbated and they end up in the hospital with their high cost issue, which are strains on the system. Now, if you're someone who has really good insurance and you have tons of money, the healthcare system spends little time focusing on helping managing your health because, well, you can figure it out on your own. And if you come in, you can pay for it. Now, this sounds a little harsh, right? but that's the reality of the healthcare system.
Hmm. Well, Thomas, as you know, I do funerals,
Yep.
and I'll talk, and this is so common. I can even ask the question. So and so passes away, and you find out that he has had, among other things, he's been diabetic, type 2 diabetes. They call it something different now, right? It basically, when you get overweight and you eat sugary foods, you're more likely to, develop diabetic symptoms. Am I right? Am I saying it right?
Yeah. Yeah, I
Okay.
mean, yeah, most no, I shouldn't say most, many people with type 2 diabetes, if they'd get their weight closer to normal, their type 2 diabetes could go away.
So this guy had had type 2 diabetes for the last 20 years. And you know what? I'll say this, because it's very common. I said, did he like sweets? And then they smile. Oh, he loved sweets.
Yeah,
And I go, okay. Well, and the reason I would say that is because, he died, I would say, relatively young. So if a guy had type diet two, and I'm doing the funeral, and he's, dies 15 years ahead of your chart line, he probably was eating whatever he wanted to. And they would say, oh, yeah, he was a terrible diabetic, meaning that he was actually an excellent diabetic
right.
because he ate everything that was sweet and wasn't tied down. And how many people do I know who are given medicine? But Thomas, this is a psychological thing, isn't it? When
Yeah,
somebody
absolutely.
says, I have to take this pill for the rest of my life, somehow we think that's weakness, right? I myself, if somebody said, well, Jeff, you're doing pretty good, but to make sure you live, I want you to take this pill every single day for the rest of your life. And it doesn't necessarily the cost, although I might bark about that. It would be like, you mean I need this? I mean, I'm dependent on this without it. And part of me says, well, what if I only take half of it? Or what if I just kind of wean myself off of this? Because I don't want to have to say to myself that I need this. Isn't there something else I can do? And then, as we know, I'll go on a diet for 14 days. That'll help. Or I'll start exercising for a month. That'll help. And we make these promises that'll help us get off the medicine, but then we never get back on the medicine. Hmm. See it
Yeah, I
all the
think
time.
yeah, all the time. One of the things that we don't do well in the United States is primary care. So if you look at the ratio of primary care doctors to specialists in the United States and compare it to Norway, it's inverted.
Hmm.
So in Norway, there's it's been a while since I read the data, but it's something like 70% of physicians are primary care physicians, and the other 30% are specialists. United States is inverted.
Hmm.
So we have way
I,
more specialists than we have primary care doctors because our focus is not on primary medicine and primary healthcare and prevention. So we should be going to our primary care doctors all the time and only seeing a specialist when we absolutely need to. But we have it backwards. And here, in many of our health systems, you don't even need a referral to see a specialist. Oh, you know what? I feel like I need to see a cardiologist or dermatologist or put your ologist in there. When really, your primary care physician is the one that should be your partner in your health and maintaining your health and preventing disease. And then, you have this significant issue. I think we should refer you to this physician. And more importantly, helping you choose the highest quality physician of that ologist, not just the one that your system says the primary care provider said should
wow.
refer you to.
As you say that, it just seems like, wow, when somebody says, hey, you don't need a referral, I go, wow, that's excellent. I don't need to go through the rigmarole of a primary care. I can just go right and see you, my specialist. Think of the money I'm saving because I actually gone through my mind on, various things. Well, good. I wouldn't need to go through a primary care physician. I can just go right to the ologist. Hmm.
Hmm.
I'm thinking that the only thing that really helps people change is relationship. I'm thinking back to those people in the Mississippi Delta, the
Yeah.
nurses who go out I think they're probably the ones. I'm assuming they see the same people on a regular basis, and once
Yeah.
they
It's
get to know
relationship
them,
based. Yep. It's relationship based.
and once it's relationship based, maybe Nurse Jackie can say to Alvin, Alvin, please, Alvin, look at this pill container. Please, I want to see you next month. Can you take these pills, please? Please. And then Alvin might go, oh, okay, all right. In a way that going in on going to the doctor and driving it is not going to have that relationship. What do you think
Well,
about that?
it's partnership, goal setting, and follow up. What's the patient or the client that they're working with capable of accomplishing before the next event, right? Nothing drastic happens before the next visit, but what's the client able to accomplish? So think about yourself. So, Jeff, you got to lose 30 pounds. I want you to do it in 30 days. That's not going to happen. Jeff, I want you to modify this behavior in your life over the next 30 days. How can we accomplish that? Jeff, you did a fantastic job. You know what? In the next 30 days, we're now going to modify this behavior. And we're going to maintain this one and modify the next behavior in the next 30 days. That's how you accomplish those goals. It's incremental, right? If you improve 1% a month over the next 12 months, what improvement have you had? It's not 12%, because remember, it's cumulative. It's much greater than that. So you're not going to try and do 10% or 50% every month, because everybody fails. I do, you do, everyone does, right? So that's what the relationship-based approach is, and looking at the whole life of a person and how to modify those. And then, because there's many things you have to address in those sorts of issues.
Just the timbre of your voice and the way you said that makes me feel bad on many levels. Just say, Jeff, what can we do in the next 30 days? What can we do? I immediately go, oh, we haven't even talked about anything. He's making me change, but that's your gift, I suppose, isn't it?
That's because your name's right on my screen, Jeff. I don't have to make one up and remember what I said.
Oh, it's getting right to me. Okay, so talk about company health plans. Yeah, and this is some of the you were telling me that when you sign up with, you work for the amalgamated chemical company and you get the company health plan, and I'll do this, and this will be, you think to yourself, well, this will be great because they're negotiating on my behalf. I'll get certainly better health care than I would if I went in by myself. Is that true? Am I making that up? And is it universally true?
There's all kinds of answers that maybe yes, maybe no. So I'll use myself as an example. So my wife and I, we buy our insurance because I'm independently employed through the ACA exchange. So we buy the cheapest bronze level plan you can buy on the health exchange. It's provided through a health insurance company, the same health insurance company that lots of people get their health insurance through. We have a really high deductible at $7,500 per person. So our deductible is $15,000 a year. And it covers very few things: preventative medicine, it covers generic medicines, and everything else applies to the deductible first. So is it cheaper for me to go through the network? And the network is where the insurance company says, this is our favored places for you to go. This is where you get the quote unquote best deal. If you go to these doctors and hospitals and buy these medicines, this is where you get the quote unquote best deal. The truth of the matter is, it's not the best deal. It might be the best deal if I get in a car crash or I get cancer or I need a heart transplant, because those are super, super high cost items. But the truth of the matter is, somewhere in 90 to 95% of people don't meet their deductible ever. In a single year, they don't meet their deductible. So if I need, for instance, I wipe out and I twist my knee and I tear my ACL and I need an MRI, if I use my health plan with my $7,500 deductible, so I go to the place that my health plan says, this is our favorite place where you need to get the best deal, well, I'll be paying 100% of it because my deductible is so high. But in my local quote unquote favored place, it will still cost me $3,500 and I'm paying 100% for it. But if I pay cash and go somewhere else, I can go see my daughter in Utah and get it for $550.
Okay, did you?
$550.
You're not making that up. Those are legit. 7,500 to 500.
3,500 to 500. Yeah,
Yeah. Wow.
I can pay cash because
Okay, I'm going to stop right now. I got to
I'm
write
still
this
paying
down.
cash. I'm still paying cash regardless. It's still 100% my money
Yeah.
because it's applying to my deductible.
So something happens.
It's just wild, right? So
let's.
oftentimes cash is the better price than using your. Oftentimes cash can be the better price than using your insurance, and I do that for all of my prescriptions. When I go to the pharmacy, I say, no, I don't want to use my insurance. I want to pay cash because the price is better.
Okay. This is where the rubber hits the road. This is going to be the most viewed segment. So I'm going to go outside right now. I'm going to trim some trees, going to climb up a ladder, going to fall and twist my knee in the same way. I'll gimp into the house. I pick up my phone. What? Okay. Now, wait a minute. I don't want to. I have health insurance, high deductible, just like you. What do I search for? Cash only health care? What how do I make that next step? I don't have to go to Utah, do I? I don't have to go out of state.
No.
Okay.
I mean, I'd go to Utah because I can see my daughter and get my MRI at the same time.
So
pay $400 for a plane ticket. You know what I mean?
Right,
so you could go. I would. There are tons of places that have cash prices for all sorts of things.
So let's just say,
and you don't have to go very far.
My metaphor is the twisted ankle, and that's going to be like some sort of orthopedic surgeon of some kind, maybe, right? Maybe, right?
Yeah, or a freestanding imaging center versus a hospital-based imaging center.
Okay.
No,
so I call up and I say, "This is what's happened," and
what's the cash price?
What's the cash price?
And then they'll say, "Do you have insurance?" And you say, "I want to know the cash price. I'm paying cash. What's the cash price?" Well, do you have insurance? I'm paying cash. What is the cash price?
Okay. And then they go,
ask for the cash price.
And they go, okay.
No, because actually the healthcare providers, for the most part, love the cash price because they don't have to bill it to insurance. They don't have to run it through a claims process. It doesn't have to go to the insurance for adjudication. It's just you come in, you pay your cash, you get the procedure done, everything's finished. Done deal.
I know chiropractors who run on that. They just say, listen, we're just tired of the rigmarole. It's just cash.
Yeah. Eliminate all the rigmarole with insurance companies who mark it up, keep a bunch, maybe deny it. It's, of course, you need an order from your physician that you actually need it. Of course, that's still important. But yeah, there's and
you do the same. You do the same with your own insulin, right?
Yeah, I pay cash. It's cheaper than using my insurance.
And how much cheaper?
Half.
Wow,
half the price.
What's the talk about the I won't say the word kickbacks because that's probably not a fair way to say it. How do drug companies how do they work in with the healthcare plans to massage their revenue? I'll just put it that way.
Yeah, there's so much going on with pharmaceuticals and prescription drug prices right now. It's astronomical, both regulatory wise and legal wise and lawsuit wise. And just go to your favorite search engine and put in pharmacy benefit managers lawsuit or pharmacy benefit manager regulations or pharmacy benefit managers congressional action, and you'll spend days and days reading. So the way, and let me back up. Let me say this a different way. When you get your medication at your pharmacy, the actual pill itself changes hands 4 times. Goes from the manufacturer to the wholesaler to the pharmacy to you. So that makes sense, right? That's kind of like any product. Mm-hmm. That's logical. The money changes hands about 8 or 9 times.
Okay.
It's the pharmaceutical distribution and markup is just wild. The most of the markup comes from the pharmacy benefit managers Now, when pharmacy benefit managers started many, many years ago, they were providing a great service.
What is that? Explain what that is. A
Yeah,
farmer.
pharmacy just what it sounds like. So, pharmacy, so all your prescription drugs. So, you have a health plan.
Yeah, yeah.
The health plan needs someone to manage when you get a prescription
Okay.
that this prescription, you get a, sorry, you have a prescription for this drug. You go to the pharmacy with your prescription. The pharmacist interacts with your health insurance. The health
Looks it up on the
insurance
screen. I see
looks it
you've
up on
got
the
blah,
screen,
blah.
says
Okay.
you've got this health insurance. This drug is covered. You have to pay this much for this drug based on your insurance plan. The insurance plan gets it from this manufacturer. This is how much it costs. And we correlate these all together. It applies to your deductible. This is how much you pay. You leave with the drug. They manage the pharmacy benefits of your insurance plan. They're an intermediary to mix from the drug and the pharmacy and your insurance. They manage that whole relationship, a necessary component to fit those together. What has happened over time, unfortunately, two significant things is the pharmacy benefit managers make a gazillion dollars on on the work that they do now, adding no additional value based on the money that they collect. And they do it in two ways. One is through rebates, or I call them kickbacks. We don't call them kickbacks though, because kickbacks are illegal in healthcare.
Can't do kickbacks.
Right.
Yeah.
So we call them rebates.
Much better.
Correct. They have an exception. They're allowed to get rebates. They have an exception, a regulatory exception. So if I'm a drug manufacturer, I pay the pharmacy benefit manager to have my specific drug placed on the formulary specifically for that health plan. So every time my prescription is placed,
the formulary is
Yep.
the list of drugs that you can get from this. Okay.
Yeah,
Right.
on your health plan, the formulary,
Yeah.
tier 1, tier 2, tier 3, tier
Yeah,
4. Every health plan has a formulary. So me as a manufacturer, I tell the pharmacy benefit manager, I will pay you, I'm just going to make something up. I'll pay you $100 every time one prescription is filled to have my drug placed as a tier 2 on this formulary. And so the manufacturers will bid back and forth. And the other one will say, no, I'll pay you $150 to have my drug placed as a tier 2.
It's that wide open.
Yeah. So the pharmacy benefit manager says, nope, we're taking manufactured drugs X because they're paying us more. So that's the rebate that they get. So the pharmacy benefit manager gets that $150 rebate every time the prescription is filled. And this is what happens with my insulin. That's why I pay cash. So they get that $150 rebate every time the prescription is filled for that drug from the manufacturer because it's sold. So the drug is sold at $300. $150 goes back to the pharmacy benefit manager. They can decide what to do with it. They can keep it. They can give it back to the employer. They can use part of it as a rebate to the person who fills the prescription. So that's one thing that they do. The other thing that they do is called spread pricing. So they might buy the drug for $30.
Hold on just a second.
Yeah, go ahead.
I just need to be sad for a little bit. It's like,
Yeah.
no.
Yeah.
The utopian world I live in is not.
It's not utopia, buddy.
Okay, so the kickback / rebates, and what was now? Okay,
now spread pricing.
Now let's continue on. Go ahead.
Okay, the other thing is called spreads pricing, or it's just plain old markup on a drug. So they might, but I'll use an example. Gleevec is a drug. It's a generic for chronic lymphocytic leukemia. It's a cancer drug. You can buy it from Mark Cuban's Cost Plus Drugs for $35. Or you can buy it through your local pharmacy that's been marked up by a PBM to $1,100 because they've
You said PBM is what now?
The pharmacy benefit manager.
Okay, yeah. Okay.
They have simply marked up the price or spread pricing what they've charged your employer-based insurance company $1,100 instead of the $35 that they actually paid for it from the manufacturer. Crazy.
Well, I can't Am I disappointed? Certainly. Am I mad? I
Yeah,
can't even say I'm mad because what do you expect? Everybody's always
yeah,
going to try to do this. It just is what
yeah,
it is. It's business, and business is the job of business is trying to increase profits. It's just the way it is. But I don't like it.
yeah.
So now we've gotten to the point where you are now, and I want to congratulate you, Thomas. You've now been made the king of healthcare. You've been I'll call you the healthcare czar. It comes with a tremendous power and authority. And I'd just like you to outline your platform to improve and get us from a C minus to D, get us as high as it can with 2 or 3 things.
So yeah, so in the next 14 hours, I'll tell you what they are. No, yeah, I thought long and hard about this question because you told me in advance you're going to ask it, and
It's a good
um,
question, isn't it? Yeah, it's a good
it
question.
is, and everyone wants the silver bullet for healthcare, but there isn't one silver bullet. There isn't even 2 or 3 silver bullets. So I really thought about this a long, long time, and so I decided to settle on the things that at brass tacks, if we were to do these things, and I'll back them up with some things why I'm going to say these would have probably the most, I think, the most profound impact. And the first one is personal participation and accountability in our healthcare. And and we talked about this a little bit. 44% of cancers are preventable. 44% by modifiable environmental and behavioral factors. So don't smoke, limit your alcohol intake, don't do drugs, make better diet choices, get out of your chair, those sorts of things. Um, Radon, those things are all modifiable things that can prevent cancer in 44% of cases. Um, High blood pressure, a lot of type 2 diabetes, heart disease. There are a lot of things that cost healthcare dollars that are modifiable in, of course, worldwide, but in the United States. So if we want to change what we all spend on healthcare, um, the first thing to do, and I do this, personally, if there's some challenge that I struggle with, and it's what do I own in this? So if I have conflict, what do I own in this conflict? What do I not like about, my life or where things are going? What do I own in this, right? It's not someone else's fault. What am I to blame in this? So I think that is a really important one. What's the personal accountability in this? The second one is inverting our ratio of primary care to specialists in this country. If we took the Norwegian approach and had trained more primary care physicians than we did specialists, I think that would go a lot further because then we would have a population that sees their primary care provider 3 or 4 times a year instead of once every couple of years or only when I have a sniffle. We would make a lot of progress in having focused on health and health prevention and not just going somewhere when, oh my gosh, I'm having chest pain or, oh my gosh, my knee hurts. We're preventing those issues in advance. That
So
would
my
have a
question
dramatic change.
is it true? I don't know that it's true anymore. That primary care physicians work longer hours, have less status, and make less money. True?
Uh, they make less money. Yep.
Okay.
They have, I don't know how you define status.
Right. Brain
So,
surgeon.
I'm not going to
Yeah,
ask that
we
one.
say, you say, what is he, a brain surgeon? We like rocket
Yeah,
scientist or
yeah,
brain surgery, okay?
yeah, yeah,
And then
yeah,
we
yeah,
say
yeah,
surgeon, and then we say
yeah.
I'm a family doctor. Yeah,
Yeah,
it's kind of
we hold
yeah,
them on a higher pedestal because they've
yeah,
gone to
yeah,
school longer and
yeah,
they make a whole lot more money. Yeah,
yes, yeah,
yeah,
okay.
that's true. But how many more lives can someone impact? A family medicine physician can impact way more lives than a single brain
Yeah.
surgeon can. I mean, I love my neurosurgeons. I know several. I love they're fantastic. They're very talented, extraordinarily intelligent. They're very gifted with their hands. But I'm talking about things from a huge macro level, And
Right,
if you
right,
want to change an entire society, you always have to have neurosurgeons, always have
right.
to have, pick your ologists, extraordinarily important, talented, capable, wonderful people deserve high compensation. But our ratio's wrong if we want to impact our society. That's what I
Well, the
mean.
reason I'm
Not
saying that,
disrespecting anybody.
the reason I'm
Yeah.
saying that is if I'm a smart guy and I get into medicine and smart people are in medicine,
Yeah.
I would say, why? Okay, so I'll just give you an example. I knew a guy who got into dermatology,
Yeah.
and he said, "You know what I love about dermatology? It's never super urgent. I don't have to come in the middle of the night hardly. It's you can see it. I come in, I live in North. I live in a part of the country where there's a lot of farmers. They come in and I scrape the cancer off the top of their ears because they wear baseball caps.
Yeah.
They go home. It's a nice gig. Nothing's really, and it pays pretty well. And so you go,
Yeah.
well, and generally speaking, I think fill in the world. The average guy says, well, okay, if I can make more money, have more status, and work easier hours.
Which one am I
I
going to choose?
right.
Yeah.
Am
Yeah.
am I wrong about that? Could you fix that?
Well, you get what you incentivize.
Thank you. Okay, so yeah, you talked about that at the beginning.
Yeah. Get what you incentivize. Yeah.
And then there was another thing. There was a third thing you were going to do. Oh, Captain Ozar of healthcare.
So, how do you think, how much spending on lobbying, how would you compare defense industry to healthcare? How do you think they
Oh
compare?
boy.
What would you guess?
Well, since you're saying it, and since you're
Yeah.
asking it, the assumption is that it's way more for healthcare. But that makes me that's another
Not
thing that's
even
making
close.
it's not
Not
even close.
even close.
Yeah.
Oil and gas industry, not even close. Not even close. And the lobbying is not about quality of care.
What is it about?
It's
I'm
about
so
access to
sad.
it's
I
about
just
access to it's about access to payment.
access to payment.
Yeah.
Access to payment. What do you mean by that?
Who gets the money?
Yeah.
Yeah.
I am
So
so
yeah,
sad.
it's been a long time since I looked at the dollars, but the amount of money that's spent on healthcare lobbying is just astronomical. It dwarfs defense spending. Oil and gas industry just dwarfs it by just innumerable levels. And I've done healthcare lobbying as a grassroots unpaid advocate for cancer research and primary and cancer prevention on the federal level. I know our senators really well. I've known our governors and representatives, and on a personal level, like on a first name level, because I've been there. And it's been about these are things that we need to do, like smoke free laws, pretty important, right? It's not about generating revenue, it's about doing things to prevent cancer research funding. I think our federal government has an important role in cancer research funding so we can find cures for diseases that just happen because they happen. I think that's really important. But yeah, the amount of lobbying on healthcare is astronomical. It's just crazy. The other thing I'm not a really big fan of is oh yeah, there's all kinds of stuff I talk about lobbying. This is one that cracked me up. So we have all sorts of things that are put in place to help health systems access healthcare funding. But did you know that there's a hospital in Manhattan that is designated a rural healthcare referral center?
Yeah.
Rural healthcare
Yeah.
referral center,
Yeah.
and it's in
In
Manhattan.
in Manhattan.
In
Which
Manhattan,
which at one time did have an agricultural base, but
yeah,
that was quite a while ago.
yeah.
It's quite a while
So
ago.
so if you think the system's broken, there's a pretty good example. Like, okay, yeah, rural healthcare has really significant issues, access issues, and all sorts of issues. And so if you design a program to benefit rural healthcare, systems. Well, we should probably make it to benefit rural healthcare systems, not that a healthcare system in Manhattan can access those dollars. It's just ludicrous, right? It doesn't work. And that's a result of how we lobby and design a system that, oh yeah, you can
So,
have those dollars, go right
a-
ahead. It's
as
crazy.
as a volunteer lobbyist, and I can see
Yeah.
you dressed right now as you are, Oxford shirt, button down, casual guy, good
Yeah.
guy, and then I
You know what?
see
I got to
Brooks.
tell you how I dress. Hang from the right, dress from the right, hang on the left. That's how I
Sure.
dress every day.
I can see you, volunteer lobbyist, and I see some guy with a Brooks Brothers double-breasted suit. Well, come on, Senator. I'm taking you to lunch in the helicopter while you're out there trying to, hand a pamphlet and have coffee with the guy. Do you get good access? Do you have good access? I mean, are you respected enough to say, wait a minute, we want to listen to this guy because he's he's a solo act. He's a free ranger.
Well, yeah, I can tell you from my perspective. So I think there's two really big differences. I have stories I can tell that they can't tell for a couple of reasons. One, because all the I told you I sent you a couple patient stories. I can tell real stories, real impactful stories. I'm not getting paid,
Yeah.
and I'm there on my own time. And the other thing that's really beneficial, living in South Dakota and in a little state, we have two senators. So does California.
Yeah.
South Dakota has 900,000 people. California has 40 million people. I have access to my senators that other big states do not. So me as one in 900,000 people, I can develop a relationship much easier than if you're one of 40 million people in other state or 10 million people, whatever the state is. So I'm really thankful for the state that I live in and the access that I can develop in a relatively short period of time and go there frequently. Other states,
Senator,
don't have that
Senator,
plus.
Senator Thomas Asfeldt here to see you.
Yeah.
Send him in.
No, yeah, no, it's not. It's not a sigh. Well, it's great because I can go if they're at the Rotary Club, having a presentation because they're out of session. I see that on the agenda, and I'll go to the Rotary session and walk up to them and go and stick my hand out and go, "Hi, John. Hi, Mike. Hey, it's been a while. I want to talk to you about this issue." And we'll stand and have a conversation for 5 minutes. And it's like, "Oh yeah, you need to talk to,
Hmm.
my current health lobbyist. Hey, here's their card. Why don't you give them a call?" That's what it's like. And that's what I love about living in South Dakota and having that sort of access. Now, does it always mean that you immediately have a change in policy? Well, of course not. But after 4 or 5 conversations and the same message, it does make a difference. I remember one time speaking with, tell you how long I've been doing this, Senator Tim Johnson. It was a long time ago. He was in the Senate. Um, he told me one time, sometimes I never get a single call from anybody on issues, unless they're really, 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 really big issues. And, we make decisions sometimes on 30 or 40 phone calls or contacts we get from people because that's all we get. And so if you think your contact with your elected member of Congress doesn't make a difference, you're wrong. It does make a difference because very few people contact them unless it's the really, really, really big issues, right? So I took that to heart to know that I have an impact on what happens nationally by reaching out to my elected members of Congress and continue to do that. And that's true for everyone. I'm not special. You're not special. Your next door neighbor's not special. You have the same access and the same voice as everyone else does. I'm just consistent.
Hmm. I'm going to just throw a couple of things by you.
Yeah.
One of the things you love about I love about the United States of America is we have 50 petri dishes. Every state gets to do whatever they want
Yeah.
on different things. And so I think one of the advantages we have is we can go to our senators or congressmen and say, this state is doing it better. Figure out what this state is doing, and that's what we should do in this state. And now you've got something, and you've got proven data, and you've got, and so if that's the case, which state is doing it best?
Doing healthcare best? There isn't one.
None of them are doing it.
No, I think
One of them's doing
there
it better. Oh my! I was gonna get
there
an
are
answer. I could sail off
no,
into the
yeah,
sunset if
sorry,
you.
Charlie.
Okay. Oh no.
There are things within states that are to be emulated within the health systems and pockets that are definitely to be emulated. And there
Okay,
are
I
and
will
you
take
can
that. I will
there you
take
go.
that. Okay,
There you
give
go.
me something. Give me a pocket that somebody's doing somewhere that we can emulate.
Okay, so I have some of my favorites. This is not to say that they're the best, but I'll tell you some things that I really like, or some organizations that I follow because um, I think that they have the right attitude and focus, and they have done so for a long time. One of those is Intermountain Health, based in Salt Lake City, Utah. They have healthcare, and I'm not going to list the states because I'm going to miss one. So they're not just in Utah; they're in Nevada and Colorado
Mhm.
and Wyoming and Montana and several other states.
Apparently, they can't leave the mountain. I can't.
No, I think that's it. I think it's the fresh elevated air, right? And who doesn't like being up
Intermountain,
on a mountain? It's
right?
great, yeah.
Yeah. Okay. All righty.
But they have for a long, long time, if you studied healthcare, you studied Intermountain Health. I mean, I remember like I'm talking decades ago, reading about Intermountain Health and what they were doing, and they're relentlessly focused on high quality, low cost. And when I say relentless, I mean relentlessly focused on high quality, low cost. It's not about how many more of these things can we do for people. It's not, oh, what's been our growth in this part of our market segment. It is, how are we serving our people for high quality and low cost? And I'll give you an example. So radiology imaging, we over image in our country. We do more imaging than's necessary. And it's funny, if anyone who works in healthcare is listening to this, and you're like, I'm never hiring that guy because he's trying
I
to drive
know.
us
I
into the
think
ground, right?
I'm
Yeah, and
right.
it's
Right.
exactly the opposite. Inherently focused on patient quality and patient outcome. So anyway, maybe Intermountain Health will hire me because I'm talking about them. But Intermountain Health several years ago their started moving their imaging out of the hospitals and into the communities. And they did this for two reasons. The number one reason was to decrease the cost of imaging, because when they were doing it in the hospital, the cost to patients was significantly higher. So they moved it out of the hospital into the community, into freestanding imaging centers, to lower the cost to the patient. Number one reason, they were decreasing their revenue.
Uh,
How
and they
many
still do.
hospital and they still, and they're doing it. They're doing more and more of it, and
Wow.
also to increase the access for the patients. When's the last time you saw your local hospital say, "You know what? We're going to intentionally decrease the revenue of one of our highest profitable services because it's good for the patient"?
Can I ask, how much of medicine do you think could be virtual? For example,
Oh, could be virtual.
I don't live near Intermountain.
Yeah.
How much of my healthcare could I get through a virtual interaction with Intermountain? Is this a possible way to enter in competition that's outside of geography?
Well, I don't know. I mean, one of the blessings of COVID was the expansion of telemedicine visits, where you see a clinician, like you and I are doing right now, via video. So you can do a lot of your healthcare visits via telemedicine. Now, what not if you need someone to touch you or poke you or make a hole in you, or do an exam on you of some sort? Of course, we're not there yet, right? But if you need to talk to someone about your symptoms, if you need mental health visits, if you need something that you don't need literally hands on you, although we're getting some technology where we can look down your throat, we can look in your ears, we can listen to your heart remotely. Some of that technology is really advancing, which I think is fantastic. You can get some of your visits that way, and I think that's been a great blessing, especially follow-up visits. You see your doctor in the office, and hey, let's have a follow-up. Is I want to see how you're doing. I want to check in and listen and talk to your symptoms. I think there's a great application for that, especially remote states like ours or South Dakota, where you might be driving 2, 3, or 4
Well,
hours for a follow-up, 20-minute follow-up visit. There's lots of applications for that.
I'm thinking, let's just continue on my Intermountain plan here. Let's
Yeah,
say that you're my doctor at Intermountain, and you say, "Hey, Jeff, why don't you go to Biff's X-Ray Shack, which
yeah,
is a standalone place. He's about 15 miles from you. Go to Biff's X-Ray Shack, and he'll send me the images."
yeah,
And I got the images, and I talked to Biff, and Jeff, you can have a procedure where you're at, or you can drive over. It'd be a flight. It'd cost you some flights stuff, and you have
yeah,
relatives. You can say it. I can do it for like 40% of that.
yeah,
Oh, and I'm wondering if that. We know that people will go to other countries to get
yeah,
procedures done
yeah,
similarly. I wonder if
yeah.
if that might be something we'll see more of.
Well, yeah. So imaging is a great example. The physician doesn't need to be present for most radiology imaging. And I'll give you an example. I'm working on my where I'm doing my interim engagement right now is actually in California. And the hospital that I'm working at, all the radiologists are remote. They're not actually on site in the
Right, right.
facility. So the technologist, the physician orders the exam, the technologist does the exam on the equipment, and then the radiologist is a couple hundred miles away and does all the reading for the exam. And you could do that anywhere in the world, right? So,
Hmm.
which is a great example of use of technology because it's fantastic. So Biff could have an X-ray shop, and he could set
Mhm.
it up and remote in a remote location. And as long as Biff is accredited and credentialed, and this technology is current and licensed by the state, you could certainly do that. And that's certainly a plus of how technology has helped us.
I talked to a man who specialized in social marketing, which I was not really familiar with, and he said
Yeah,
it's like this. It's like this. And his example was you get your energy bill. And what we're trying to do is get people to use less energy. That's the premise. Well,
yeah,
you get the bill in the mail, and it has next to the bill a little smiley face. And it says, "Congratulations, Jeff. You beat all of your neighbors. You used 12% less energy than they did." Or then you had a neutral face, or you had a frowny face that says, "Sorry, Jeff, you spent 12% more," and I'm just going to offer a suggestion. Have you considered raising, and it gives you a little sample of what you could do, stop running the air conditioning or run the dishwasher, do these things. And maybe next month we'll see if, congratulations, Jeff, you get a smiley face. You used 1% less than you did before. And the idea is that the social marketing, people do what to win, so to speak, to have other people feel good about it. And I'm wondering if any of that social marketing could be or is being used for people who need to take regular care of themselves but are avoiding that. It's a genius. Apparently, I have a genius idea. Do I have a genius idea? Thomas, am I the first guy who's thought of this?
um, no, there is.
Wow.
No, I'm gonna say I think particularly in the mental health space, there are lots of indicators. Particularly, uh, are anybody using this? No, so I'm gonna start over. In electronic health record space, we collect so much data on patients. We don't use very much of it. About it was probably 5 or 6 years ago, Microsoft examined the amount of information that we collected from electronic health records and how much we used. We used about 3 or 4% of the data that we collected. It's higher now than it was back then, but it was very little. What electronic health records are able to do to us is what you're implying. I'm a little bit avoiding your question about social media, but it's about data collection and using data to identify challenges. So in electronic health records, because we collect so much data, it identifies problems that the human, because there's so much data, can't pull out all of it. So Jeff may come in regularly and see your primary care provider or your specialist, and all this data is collected. But because each of those visits are for a very specific purpose, for an isolated instance, for an isolated issue, um, all those pieces aren't put together.
Mm.
However, with large language models and artificial intelligence, can accumulate all that together and identify an issue that wouldn't have been identified otherwise.
Mm.
And that is going to become, or is becoming, really helpful in that, oh, you know what? The trend in Jeff's issues of those separate visits to these separate providers identified issue X, not issue Y or Z that he saw these other providers for. So that is actually going to be a very future-oriented, very helpful tool, actually currently helpful tool that's
Right,
already
right.
being leveraged.
How
Yeah.
many times do you go to a doctor and the person wheels in and he or she looks and going like, okay, and they're just now you're just now reading this, aren't you?
Yeah.
Okay, Jeffrey, it looks like yeah, I can tell you're just now with me reviewing stuff,
Yeah.
and I can tell that you're on an 18-minute clock and you got to get out of here. So you're not really you're just trying to get up to speed. You don't really know what's going on with me.
Yeah.
And to
And that
your point, to your point, the large language model, the chat, whatever, could say, when you walk in, ask him this question. Now, Jeff, you've had some issues with acid reflux, and you are now have you had, is there, ask him this question. And I can read that question and interesting. And so that will help the doctor keep up with his or her busy rounds, but also use, as you say, all of this data that we are not mining to its full extent. Hmm.
Yeah, or they don't want to. Thing that has to be careful, and this also be identified to not dumb down the providers, and that decrease in their decision making capacity, and that it'll do things like note Jeff went into acute care 2 weeks ago for the complaint of this.
Ah.
How does that tie into the clinical picture? Jeff went into the ER up in Watertown 3 weeks ago with this issue. How does that tie into the clinical picture? So that the clinician can see all of the aspects of what's going on in Jeff's picture, to help correlate all of those aspects of Jeff's real entire health picture to make a better clinical decision. Because the clinical decision still is the clinician. It's not a computer's not going to do that, because that's not what you want. I think evidence is going to show that the computer is not, or the AI is not the tool that we want to do that. We want the AI to make sure and grab all the relevant information that we may miss, in the large screen, in the large picture, and in Jeff's entire data set, but not to make the decision for the clinician so that they're too focused on this one issue that the AI says we think we should look at.
My brother, when he started out, said that, they always said a new broom sweeps clean. And it was the new guy, the new, very new doc, who would ask the question of, have you been in a foreign country exposed to tropical diseases? Is that
Mm,
a possible reason why you have a runny nose? And then the years go by and, they say no, 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 no. And after year 14, you stop asking that question because nobody ever answered it to the positive.
yeah,
And that's one of the advantages I see to AI. It will ask that question that you go, okay. Or maybe you will do a pre-warm up and we'll ask that question. In my experience, in every single field of everybody, to use your curve, um, what do they say? The guy who graduates the last in med school, you know what they call him or her? They call him doctor, right?
yeah,
And we know for a fact that there are bad plumbers and there are bad dentists and there are bad, car mechanics. and there are bad doctors.
Bad
You got me
storytellers,
bad storytellers. I tell you
bad
what.
administrators, bad
Oh my!
contractors, bad interim executives. You always got to put yourself in there so that you have
Yes.
credibility, right?
That right to the quick. He went. That hurts. That hurt. But I needed to hear that. So can you give
You're
me?
a great storyteller, by the way.
Oh
But
no, no,
it's
no!
to make a point, right?
It's
Whenever
to
you
make.
say those sorts of things, you have to include yourself in the pile.
Yes, that's good. I got to write that down. That's my number one. Okay, for behind the scene, I mean, how do you know? Is there a thin slice way to make sure that I get the best one?
So there is lots of data out there. Unfortunately, most of it is not accessible. The one thing I tell people is this: go where your doctor goes to get their care, or where they send their family members to get their care.
Oh,
Mhm. Don't go
interesting.
where the doctor or the health or your insurance company refers you. Go where your doctor gets their care, or where your doctor sends their own family to get your care. That's a really good surrogate measure of where the best care is. Because
Because
you'll notice something that, your insurance company has their network. We want you to stay in your network because that's where we as an insurance company makes our most money. That's why you want to go here. It's not about quality most of the
yeah,
time. I can tell you that it's mostly about where do we make our most money. We want you to stay in our network. This is where our contracts are. And most of the doctors, because I love doctors, right? But they're influenced by the health system they're working in,
yeah.
and they're tracked by where they refer their patients, and they're pressured to refer patients within the system. Everything's on the bell curve. The 10% in the top say, I could care less what our health system says. I'm referring our patients to where
Hmm.
they get the best care, and good for them. 80% are in the middle. They've given in to all the pressure that they get. I got to refer within the system because that's where my payment comes from. That's where I get the most equipment because our money stays here, et cetera, et cetera, et cetera.
Or to that, you'll sit down with your doc and they'll say like, okay, how come you're not asking people to have this particular test done? Well, I didn't think they need it. Well, you know that we make more money when we have people do tests. How come you didn't do this test? And our pattern shows that you're not asking people to do this test.
Well,
So
I
you go,
think
"Wait,
I think
yeah,
most
yeah,
no, I think most physicians practice under evidence-based guidelines. They really do. Because I mean they just are. Physicians are physicians. They're guided by the Hippocratic Oath, and that's how they operate most. And but it's where do they refer them to do
yeah,
it? They may have a piece of equipment that is, or person within their own system that maybe is not the best. There's someone who better, or maybe doesn't do this one procedure as often as they should. I'll use an example. So if you have pancreas cancer and you need a procedure called a Whipple procedure,
mhm,
there's evidence that shows if you don't do X number of Whipple procedures every year, your quality is significantly worse than if you
oh,
do X number or more. So if you need a Whipple procedure and your physician refers you for a doctor within the system, and you ask your doctor just refers you within the system, oh, this guy, he does Whipples. And I say, well, how many did he do last year? And the doctor says, oh, I don't know, he does Whipples. Well, how many did he do last year? And I know this because, these are things that I look at. If my referring physician doesn't know how many, I'm going to say, why don't you know? Because you're referring me to this physician. I want the best quality outcomes for me. I could
yeah,
care less about your system.
yeah,
I want what's best for me.
yeah,
So, can you tell me how many Whipples this physician did last year? No, I cannot. Thank you. I will find my own place to get my Whipple
wow.
because I want a physician that does more than X, which the evidence proves has higher outcomes. So, because there's so many physicians and so many outcomes, and it's hard to get the data, find out where the doctors go to get their procedures, and you will almost always find where the best outcomes are.
Well,
It's a good
because I,
surrogate.
I because I like Because I like suspense movies, I have a bad
Yeah.
feeling that in my mind, you're going to be at coffee someplace and an anonymous guy with dark glasses is going to have coffee next to you and he's going to go, didn't like what I saw on the show, you know, cut it out. I mean, I hope I'm not hurting you professionally. I feel like people leave this guy alone. How can we, people are watching. How can people interact with you? How can I help you? Help you? Because I think you're doing great things in the world, Thomas. What can I do to help you?
Well, I mean, here's the reality of it. Um, in the last 25 years, health insurance has gone for a family has gone from $6,000 a year. This is United States average, $6,000 a year to $25,000 a year.
And that was
If
what?
that
Say that again.
in the last 25 years,
Wow.
if that trajectory continues and it's continued unabated, if we wait another 25 years, the only reason you will go to work is to pay for your health insurance.
Hmm.
Because it'll be over $125,000 a year for your health insurance. So if we don't start to think about these sorts of things seriously and do dramatic things about it, I mean, our country will cave under the cost of healthcare.
Mhm.
It's same thing like with our national debt, right? And the national debt and our spending, 70. I asked Senator Thune about this when I was talking to him a couple months ago. I say, how much of our deficit and debt is healthcare spending? Oh, I don't know, 74, 75%. So, I mean, if we don't think that's an issue, um, we're gonna be in significant dire straits, and we don't have to be.
And if what
So
I heard you
it's
say earlier, let's just say somebody comes in, we're only going to pay what they make in Cuba. Well, suddenly you're telling me we'll live longer. So, right? I
right,
mean, yeah,
but you
interesting.
won't get any of the big fancy stuff.
Yeah.
You'll get your vaccines, you'll get primary care, you'll get your hypertension taken care of, your diabetes taken care of. But if you most people, if you need a pacemaker, you know, sorry, you won't get it. But as a whole, we'll all live longer, right? And I'm not
Hmm.
saying we should go to Cuba, of course. I'm just saying that's a
Yeah.
crazy
Yeah.
example of why in Cuba is the life expectancy 4 years longer. It's not, absolutely not. I'm advocating for that. I like where I live. Um,
Yeah. Yeah.
uh,
Yeah. I hear what you're saying.
yeah,
I was
of
just
course. You
using
know what I
it
mean?
as a,
It's
yeah.
it's just an example. It's just crazy. We should have much longer life expectancy than them. They're living in the dark right now because they have no
Yeah.
power.
Yeah. So
It's wild.
here's, I can't, okay. Oh my goodness. This is a long interview and I'm going to wrap
Yeah,
it up
sorry.
for you. No, 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 no. I
You
want
got
to
10 questions
apologize.
you haven't asked me.
Yeah.
I prepared for 10 other questions.
I,
You never asked me.
what are the questions? I'm just going to say, if people have a way to get a hold of you, or how do
Yeah,
we? I know you sent pictures of your family. Want to get those up here? You're a family guy. You're a Christian man. That's how we first met many years ago. You're a
yeah,
man of
yeah,
faith.
yeah,
And we see each other in around the community. And
yeah,
I just didn't know the depth of your expertise. And whenever you run into somebody and find out those things, well, you never have the time to dive deep. So
yeah.
I think like we did dive deep, but we could go back and dive again. So my questions to the audience, right? If you have any further questions, you can comment on those and send them. And then we'll have Thomas maybe come back and answer those because
Yeah, that'd be fun.
I think Thomas could be a fairly regular guest if you ask questions, don't try not to make them specific about your issue, but try to make them about the whole industry because this conversation that we're having is something that needs to be happening more often with more people because no, I don't think anybody really likes it. Even people who work in it, I think they're kind of like, I wish it could just be better. And
Yeah,
why not
it's
just do
very
it for
true.
all of us? Yeah.
Yeah, it's
So
very, very true.
we have time for one more question, Thomas, and that's your question. You can ask me any question you want, any question, but it's only one question. I'm only going to answer one question. What is it, Thomas?
Okay. I'm going to ask you the same question I ask everyone that I interview for a job. It's the last question I always ask them. What question do you wish that someone would ask you that you always have wanted to talk about, but you've never had the opportunity to do so?
Okay. This is a fairly difficult one because I'm kind of an open book. People ask me all kinds of questions because I'm a curious person, they're curious back. Um, I guess to a larger question, how are you doing? Would be the question. How are you doing? And the reason I ask that, that's a question I don't get asked a lot, is because I do get asked it a lot. And the answer is
Mm,
always fine, pretty good, fine, pretty good. But to me, I'd like that to be like when you go to the doctor, a full round of questions, mentally, socially, historically, dreams, day to day, and just, what is the full, what is actually going on in your head? Where are you? How much of this is based on your own, fantasies in your own head, the old preconceived notions? How much of it is God driven? Where is it? Where are you at? And if our job is to follow God's path, how am I actually doing? And it's I would say it would be a little bit like a golfer and his caddy. So I'd kind of like to have a caddy question where the caddy would come alongside of me, and I guess I'm on hole 17 here, maybe hole 16, and he's coming alongside, and as I'm crouching down, he said, "So, how's it going?" I said, "I don't really know. I don't know what par for this course is. I don't know what the lie is. I don't know if I'm using the right club. I don't know if I'm following the rules. I don't know if I can use a mulligan. I don't know a lot of this stuff. Do you?" And then the caddy might say, "That's kind of a weird course." And then we would have this conversation, a real conversation of the mystery of this game called life, which is so complex and so fascinating and so frustrating and so delightful and so strange. Did that answer your question?
yeah, it's an open-ended question to get people to share something that everyone's got something that's hanging there in an interview. It's like, "Oh, I hope I get to tell this about myself in an
Mm.
interview." Something that's just like, "You know what? I have this thing hanging on my heart that no one's ever asked me about, so I don't dare just share it because it's X, Y, and Z." So, I think you get to ask a lot of questions with your people that come on, but do you really get to tell that one thing that's no one's really asked you, but you've always wanted to talk about it? So, sorry, I flipped the
Yeah,
script, man.
Abraham Lincoln was at one time said, I wanted to cast a long shadow." And he grew up at a time when America was just figuring out how this
Mhm.
democracy could work.
Yeah.
And everybody of his ilk, everybody who was the best and the brightest, the smartest guys in the room, they all were going into politics because this American experiment was just kicking along, and and he thought he'd missed his chance because the nation was up and he just didn't get his chance to cast the long shadow. And I find myself resonating with that comment.
Mm, mhm.
How am I casting a long shadow? Am I? Should I? Where am I? And these are questions that I think are common to many of us. And when you work for the man, as I do, uh, I stopped working for the man and now I work for the man.
Yeah.
And so I get up in the morning and I'm talking to you and I'm enjoying our conversation. But the question is, was I supposed to? Was that my job today? Was it? Maybe. I think so. But in my efforts to cast a long shadow and following my path, I'm just curious if I'm doing it right.
I think you're doing it right. I've
Mm.
seen or heard you tell lots of stories.
Yeah.
You're using your gift.
It's a strange one. Yeah.
It's a good
And
one.
you were using your gift. You have this unique many people who are super into data are not really into people. And you're at the crossroads. You're a very compassionate man who also happens to love data. And that's kind of a unique double skill set. And you are perfectly placed what I love about what you do is you can walk into an existing, we've always done it this way sort of environment, shake it up a little bit, get some people around, and then like, who was that stranger who came through our town, right? And I think that that is maybe exactly what God's placed you to do. Well, hey, Thomas, I don't think this is the end. Again, comment, share, like, subscribe, as they say, and all that other stuff. And we'll see if we can have Thomas back to answer some of these deeper questions, and especially in healthcare, because as you know, if you just ask the algorithm a health question, it's going to send you down some kind of a rat hole that you just can't hardly escape because you don't really know if you're getting the right answer, right? So, yeah,
Right.
really
And
appreciate that.
and ChatGPT is only right 60% of the time for health questions currently, so be careful.
Wow. That's you saved that bomb for the
Yeah,
last.
there you go.
This is why people hang on to the end of this show, right? All
Yeah,
right.
there you go.
All right. Well, I'm Jeff Gould. Thanks very much for joining us today. And our guest, Thomas Asfeldt. We really appreciate his insights. His contact information's on the screen. Reach out to him if you're a healthcare system in need. Man, do we have a cowboy hatted stranger with a white hat who's going to roll into town and fix your problems. All right, everybody. Have a great day. God
Thanks,
bless.
Jeff.